Really, we do a full physical assessment. So when you're washing them, you might not do it formally, like you're going through every single thing, but you're assessing them. When you wash them, you're looking at their skin, you're looking at if there's any excoriation. People are incontinent, so you're giving them incontinence care. So while you're doing that, you're monitoring if their urine output looks good, if it looks like a significant amount of urine, because if your urine output drops, that could be a sign that they're becoming unwell. You're looking at if their urine is concentrated, if they're getting enough hydration. So you might be just changing a pad, but you're doing a number of things. You're looking at their skin, you're looking at their urine, you're looking at their bowels. Are they constipated? Are they loose? Is the loose bowels overflow, which would be a sign of constipation, or is it because we're giving them too much laxatives? Have they got a neurogenic bowel? So are they emptying fully? So even though they've had their bowels open, do we still need to give them a suppository, to make sure they've emptied fully? So there's a lot to sort of assess, and that's just their incontinence, So then we change in their position every 4 to 6 hourly. Some patients need it more frequently. Other patients we're trying to work towards 6 hourly, because if they go to a nursing home, they haven't got so much staff to do such frequent turns. So we need to try and build them up so that their skin can tolerate longer periods in the chair, longer periods on their back when they're asleep. So when we do their wash again, we're assessing their mouth, we're assessing their eyes, and listening to their chest, I suppose. Their breathing, if they sound like they're coughing, we're going to think, oh, okay, then do they need the doctors to listen to their chest? Are they developing a chest infection? What colour are those secretions if they are coughing? Their bowel, their stomach, does it look distended? So we do their obs as well generally. So we're kind of, although we're just washing them and then doing a set of obs, we're kind of looking at all of the system, isn't it? So looking at their blood pressure, it's all monitoring how their state of health is, I suppose, isn't it? If they've got a high heart rate, why is that? Is it because they've got discomfort in their bowel? If they've got pain, are they in a bad position? Or are they distressed, isn't it? It's emotionally, psychologically, if your blood pressure's up, that's a sign of stress, isn't it? And then we're also making them look nice. We're brushing their hair, we're showering them and dressing them, getting them ready for their department so that they can participate in rehabilitation. You're looking at their toenails. Are they growing too long? Are they digging in? Do we need to get a podiatrist? So it's a lot of assessments, even though it might just look like we're doing a wash, And then you're acting on that, isn't it? Okay, they're a bit chesty, we better get the doctor to see them, or whatever. Their teeth are a bit wobbly, we better get the dentist out, or whatever, So yeah, so that would be their basic nursing care. And of course then they have their routines. At 6 o'clock they start their feed. So if it's via an NG tube, I'd have to teach the students. If we're talking about how I would teach it, we need to make sure that tube's in the right place. We check the pH, because if the aspirate, when we take a little bit of fluid out of that tube, if it's acidic, that means it's in the right place. It has to be in the stomach. That's the only place that would produce an acidic reading. So it's okay to give the feed through that tube, because we wouldn't want it to go in the lungs, which could cause a chest infection or death if you were feeding them into the lungs, isn't it? With a peg, you don't have that worry, because it's going straight into the stomach. So you tend to start their feed and give their prescribed medications around 6, and then we decide when they're going to be washed according to when they were last turned or what therapies they've got. We then get them up in their chair, and then we assess how long they can stay in that chair. If they're comfortable, get them back in. We might help with splinting, and at least removing the splints after the physios have put them on. And then overnights, we're looking at their sleep pattern. We're trying to get them into the correct sleep-wake cycle, because sometimes people are awake all night and asleep all day, which, is not great for them participating in their therapies. Their SMART assessment, they need to be as alert as possible. So we use things like melatonin to try and get them to sleep at night so that they're awake in the day. Because you might think, well, why do we need to worry about their sleep-wake pattern? But I suppose it's because in order to get the most effect, the right assessment from their SMART, they need to be as alert as possible, isn't it, for you to assess them? So we do try and get them into a more normal sleep cycle. have I thought about all aspects of the nursing care there? There's feeding, pressure care, incontinence care, medications, and then of course a big part of my job, I think, is being with the families.